Giacomo, ladies and gentlemen. So each time we ventilate a patient, there is a risk of ventilation-induced lung injuries. Viley, in normal patient, increase the risk of secondary ARDS. In ARDS patient, we know very well that it increases the risk of mortality. And in surgical patient, it increases the risk of pulmonary complication after surgery. Ventilation-induced lung injuries is a combination of too much stress. Stress is too high pressure in the baby lung, too much strain, too high tidal volume as compared to the volume of aerated lung, and atelectrauma, which is repeated closing and opening of distal airways and alveoli. A new word has appeared regarding Viley, which is called ergotrauma. Ergotrauma refers to the mechanical power provided by the ventilator applied to the lung, has an energy load and a dynamic energy load. And ergotrauma can be calculated with a quite complex formula, which is more or less the equation of motion, and it takes into account the tidal volume, the rate, the driving pressure, the inspiratory flow, and the PEEP. So all the components of the mechanical ventilation. How to prevent ventilation-induced lung injury? To prevent the stress, we should limit transpulmonary pressure, or if we don't have it, plateau pressure. To prevent the strain, we should limit tidal volume and driving pressure. To prevent atelectrauma, we should use the lung recruitment strategy. And to prevent ergotrauma, we should limit as much as possible the minute ventilation in order to limit the mechanical power. And for a given minute ventilation, we should try to optimize the breath pattern in terms of tidal volume, flow, and respiratory rate. So, another point about mechanical ventilation is oxygenation. As you know, if we plot PaO2 and the risk of death, patients with a low PaO2 of course have a high risk of death, but patients with a high oxygen, which is called hyperoxemia, have an increased risk of death. And not only hyperoxemia, but the time spent in hyperoxemia also increase the risk of death. And hyperoxemia is defined as a PaO2 above 15 kilopascal or 120 millimeters of mercury. And this is quite common in the ICU, occurring in 20 to 25% of ventilated patients. Well, there is a prospective randomized control study that compares two strategies for the target SpO2, a conventional one, 97 to 100%, meaning a high risk of hyperoxemia, with the conservative one, 94 to 98, and as you see, the survival was better when we use the conservative approach. So it's not only a matter of volume, pressure, ergotrauma, but also oxygen is lung protective. How to protect the lung? Well, if we want to protect the lung, given all this data, we have to take care of all these parameters: tidal volume, driving pressure, plateau pressure, respiratory rate, flow, minute volume, lung recruitment strategy, and to keep normoxia for every patient in the ICU. So it's a full-time job. If you want to optimize the lung protection in your ICU, you have to go from one patient to another and back, and you spend your time doing this. So it's very difficult to do in the real life. How is it done? We don't have results for all the patients, but thanks to Giacomo, we have some results for ARDS patients. In the LungSafe study, they reported that only 34% of ARDS patients are recognized by the clinician at the time of fulfillment of ARDS criteria, that overall only 60% of ARDS are recognized by the clinicians. And the problem is that, of course, patients that are not recognized are not treated as such, meaning they are treated with, they are managed with higher tidal volume, lower PEEP, and they receive less adjunctive therapies, just such as prone position or myorolaxant. They showed also that 35% of ARDS patients are ventilated with a tidal volume over 8, and that 83% of the patients are managed with a PEEP below 12 centimeters of water, and that only 40% of the patients we measure or we control the plateau pressure. So let's say that it seems that there is a room for improvement in what we are doing today. So how can closed-loop ventilation help? INTELLIVENT-ASV is a full closed-loop ventilation mode that manages both the ventilation parameters and the oxygenation parameters in passive and spontaneous breathing patients. So it's quite simple. The user has to set a target end-tidal CO2. The ventilator will measure the end-tidal CO2 of the patient and adjust the target minute volume to keep the patient end-tidal CO2 in the range. For a given minute volume, it will measure the respiratory mechanics of the patient, namely the expiratory time constant, and determine a combination of tidal volume and respiratory rate according to the ASV algorithm. It's a pressure control mode, meaning that it will use a pressure control breath and adjust inspiratory pressure to reach the target tidal volume. For oxygenation, the user has to set a target SpO2. The ventilator will measure the patient SpO2 and adjust PEEP and FiO2 according to a PEEP FiO2 table to keep the patient in the target range. So the user has to set the controllers, minute volume, PEEP and oxygen, has to set a patient condition. By setting the patient condition, the ventilator will propose different default target range for end-tidal CO2 and SpO2. The user, there is a quick win protocol. The user has to set the minimum and maximum PEEP, the range of PEEP. And very important, the user can select any target for the end-tidal CO2 and SpO2. If the default target range do not fit for a particular patient, we can always shift it. So this closed-loop mode has a lot of lung protection features that are by design, and I will describe some of them. First of all, it allows a sort of automatic permissive hypercapnia. Look, this is the end-tidal CO2 ranges. So, for example, we set between 36 and 43 as a target range for end-tidal CO2. But the y-axis is the peak pressure. If the peak pressure goes above 25 centimeters of water, by design, the end-tidal CO2 target will be higher. So it's a permissive hypercapnia in case we need high pressure. Of course, you can also shift it and use a permissive hypercapnia even at low peak pressure. The second thing is ASV. ASV algorithm is a way to optimize the mechanical power. You know very well that ASV is based on the minimum work of breathing principle. This is the first version of ASV. 2 years ago, ASV was modified and it was introduced the MID formula, which is the minimum force of breathing. What is the difference? The minimum force of breathing is the minimum inspiratory pressure for a given minute volume and a given respiratory mechanics. And so the new version of ASV that is available for more than 2 years now combine OTIS and MID, so combine the minimum work and the minimum force of breathing. And this is more or less the minimum mechanical power for a given minute volume. So ASV by design will adjust the target tidal volume to the respiratory mechanics. This is an example on a simulator. It's a patient with 66 kilograms of projectile body weight, ventilated with a normal minute ventilation, and the respiratory mechanics is normal. Compliance is 60, resistance is 10, it's normal case. You see that the ventilator will determine the tidal volume at 423, which is 6.4 milliliter per kilogram of projected body weight. If the same patient decrease the compliance to 32, which is a simulation of an ARDS case, you will see that with the same minute volume, it will decrease by itself the target tidal volume to 4.6, so quite low tidal volume, and a higher respiratory rate. So what I mean is that even if the clinician is not aware that the patient worsens, the ventilator will adjust the breath pattern automatically. Another feature is the open lung PEEP FiO2 table used by INTELLIVENT-ASV. This is PEEP, this is FiO2, this is a low PEEP FiO2 table and the high PEEP FiO2 table published in the ARDS-net publications, articles. INTELLIVENT-ASV used an asymmetric table, meaning not the same table when we have to increase the treatment, where it used more or less the low PEEP FiO2 table, and when we have to decrease the treatment, where it uses the high PEEP FiO2 table. Meaning when SpO2 is too high, it will decrease first FiO2 and then PEEP. This is the open lung concept. And you can read it on the screen. So what are the results about all these features? In this study we include, it's an observational study where we include 255 patients, passive patients, and we look on the first day of mechanical ventilation, what was the ventilation selected by INTELLIVENT-ASV. We split the full group in normal lung patient, COPD patient, and ARDS patient. And as you can see, regarding the tidal volume, it's between 6 and 8 for normal lung patient, a little bit higher for COPD, and between 5 and 7 meters per kilogram of projected body weight for ARDS patient. For the plateau pressure, it's below 20 for normal lung patient and below 30 for COPD and ARDS patient. And regarding the driving pressure, which is plateau pressure minus total PEEP, you see that whatever the lung condition, we find a median driving pressure between 9 and 10 with a range between 8 and 12 centimeters of water. This is the ASV algorithm with the mid formula that keep a low inspiratory pressure and a low driving pressure. We looked a little bit more in detail in the subgroup of ARDS patient, and we split the subgroup in mild, moderate, and severe patient. And again, you see regarding the tidal volume is lower in the most severe patients. The plateau pressure was always below 30, and the driving pressure is not so different according to the severity, again, always between 9 and 10 has a median value. In a small subgroup of severe ARDS patients, we introduced an esophageal catheter to measure the transpulmonary pressure, and we found that, so it's only 21 patients, we found that the transpulmonary pressure at the end of inspiration was 8 centimeters of water. You know the recommendation is to keep it below 15. And the transpulmonary driving pressure was at 6 centimeters of water. There is no recommendation because we don't have so many data, but probably we have to keep it below 10 or 8 centimeters of water. Last thing is oxygenation. Of course, if we use a closed-loop oxygenation controller, we set a target and the ventilator will decrease FiO2 to keep the SpO2 in the target range. And so this is a wonderful tool to prevent hyperoxemia. In this study, vast study, we include 100 unselected ICU patients ventilated in INTELLIVENT-ASV from intubation to extubation. They were ventilated for 4 days, so we have more or less 400 arterial blood gas in different lung conditions, normal, ARDS, COPD, and others, and we didn't find a single case of hyperoxemia. In the last study that we performed in 255 patients, also when we look at the blood gas, we didn't find a single case of hyperoxemia. And we recently performed a randomized controlled trial comparing INTELLIVENT-ASV versus conventional ventilation in patients ventilated more than 48 hours. And we compare 30 patients ventilated in conventional mode and 30 patients in INTELLIVENT-ASV. And when we look at the blood gas, all the blood gas of this patient, we found 17% of blood gas with hyperoxemia in the conventional group, and it was decreased to 10% in INTELLIVENT-ASV. Why 10%? Because at that time, INTELLIVENT-ASV went down to FiO2 of 30%. Now you can go down to 21, so probably we would get less hyperoxemia, going down to 20%. We look also at, do we create more hypoxemia? So we look at the number of blood gas with the PaO2 below 60, and we didn't find any difference between the two groups. So to conclude, lung protective ventilation is for all the patients continuously. It's a multifaceted strategy, so it means that it's difficult to apply in the real life at the bedside. INTELLIVENT-ASV combines several features to protect the lung that can help the clinician to apply lung protection. And we have quite interesting results in terms of tidal volume, plateau pressure, driving pressure, and oxygenation. Thank you for your attention.